Nice to be here. Just about over 20 years ago, I was asked to mount a concussion management program for the Chicago Bears and made probably my best professional decision to put my hard-charging young postdoc, Mike McRae, on the job. And basically, I've ridden Mike's coattails ever since in the field of sport-related concussion. And what was funny is that in 1995, every single hypothesis that I had about sport-related concussion proved to be wrong, and basically was overturned over the course of a couple of decades of research. And that's not maybe bitter or cynical, but certainly skeptical. And so I'm going to give you a skeptic's sort of perspective on this issue today. The only relevant disclosures is that I've been asked to present my perspective to various opposing groups, and I've told them both the same thing. And I have no other relevant disclosures for this talk. So what I want to do is just talk a little bit about the short-term risks, natural history, Mike's touched on some of that, the role of management strategies to the extent that they exist today, and then a little bit about long-term risks, focusing on epidemiology, and then what's out there today in terms of survey data and clinical studies. So, there are a lot of myths that are propagated by the media. So the myth number one is that there's credible scientific evidence that an uncomplicated concussion, by an uncomplicated concussion I mean no bleeding, bruising, swelling of the brain, can produce long-lasting or permanent impairments, and there really is no credible evidence. So Mike's touched on this, and Mike and Kevin really kicked this off back with the NCAA studies and multiple studies since, and other folks have done it as well. So we have this laboratory, this SLAM, sports laboratory model. We know that we're going to have 3 to 5% per season incidence of concussion in football, for example. So we have these prospective controlled studies where we can actually track people and see when they recover. And this didn't exist in 1995. We had no idea, really. So you've seen this paper referenced here, and this is the objective. That initial study had about 3,000 football players. We did the concussion symptom checklist and balance testing and the neurocognitive testing over time. Basically, here's symptom recovery. You've seen that multiple times now. Here's cognitive recovery on the SAC, which is pretty quick. By day 2, we don't see the difference between groups. Here's the postural stability recovery on the BESS, again, very quick. Okay. And one of my first hypotheses was that neurocognitive testing was going to be the thing to detect persistent impairment in concussion, and it's terrible at it, quite honestly. As a neuropsychologist, it pains me to say that, but it's true. And if you look at the effect sizes, and I was kind of hoping Mike would show this, but the effect sizes for self-report symptom checklist data are much larger than neurocognitive testing or balance testing at any point in time. So the idea that athletes underreport their symptoms may be true, but what they report separates them from non-injured athletes at a much higher level than anything we can measure objectively. So Bellinger published a review, a meta-analytic review, that basically concluded that no prospective controlled study could identify any neurocognitive impairments after about 7 days post-injury, and that's held true to date. What happens if you've had more than one concussion? The data out there are very limited on this because it's hard to come by large numbers of athletes who've had multiple concussions. So Kevin was the first author of this paper in 2003 that said if you've had previous concussions, your risk of getting another concussion seems to be higher, and that's been reported elsewhere. It may be associated with slightly slower, but no less complete recovery. And then interestingly, multiple studies that look at baseline performance on tests like the IMPACT and other tests show no influence of history of concussion. So people that have had 2, 3, 4, or 5 concussions aren't performing any worse on their baseline testing than someone with no concussions, suggesting that there is probably not a cumulative, at least a measurable cumulative impact of concussion on neurocognitive status. So interestingly, and now the third speaker to touch upon non-brain injury factors that impact on post-concussive symptoms, which you would never have heard at a sports concussion conference a few years ago. But so myth number 2 is that post-concussive symptoms are always or even mostly due to brain injury. And the clinical neuropsychologists know this to be not true because we see them all the time in other patient populations. So these symptoms, you should be aware, are highly nonspecific. They occur at high rates in a variety of conditions, including psychiatric conditions, depression, PTSD, anxiety, and so forth, and they play a major role in symptom expression. So when we look at emergency department studies where we enroll people who have had concussions as well as people who have had orthopedic injuries, at 6 months after the injury, after your emergency department admission, your score on a post-concussion scale is not predicted by whether or not you had a concussion at all. So brain injury is not even a predictor. It goes to what Mike was saying in terms of your baseline psychological makeup playing an influence, but other factors influence your post-concussive symptom reporting at time points that are far out from the injury, mainly current levels of psychosocial stress, anxiety, depression, and some other baseline psychological factors in terms of your psychological makeup. So in terms of these short-term studies, what we know about concussion in the short term, and by that I mean days, weeks, and months, that we do see these measurable changes in neurocognitive status and postural stability and subjective symptoms, the latter being the largest effect that we see. They occur immediately post-concussion when you have the maximum deficits and symptoms right after the injury. Recovery is very rapid. It's very difficult to detect at a group level any significantly measurable difference between groups after about 7 days. And persistent post-concussive syndrome is currently fairly rare in athletic samples, but strongly related to psychological factors in clinic populations, and that's something to be aware of. Okay, management strategy. So I'm going to poke a hole in this a little bit too, probably. A lot of the management strategies, or all the management strategies essentially to date, are based upon opinion and not really upon evidence. There's actually just, Mike mentioned the first controlled study, which is interesting, I'm going to touch on in a second, but there really is not one there hasn't been to date a controlled study about how to manage concussions. What do you do with these athletes? So it's all on personal preference. So the one thing that I think everyone has always agreed upon over the years is that the one thing you can do for sure is not return a player to contact until they're symptom-free. That seems like a no-brainer, no pun intended. But only one study's ever looked at it. I'll take the credit for the idea. Mike as usual, carried it out. But we had accumulated 640 concussions from 3 prospective controlled studies. And I said, we were sitting around talking about our data one day, and I said, I bet some of those athletes were returned to play before they were symptom-free, because we didn't control return to play. That was controlled locally. I'm thinking, even if only 10% of them were returned while they were still symptomatic, that's 64 players or something. Well, it turns out that 40% of them were returned to play while they were still actively symptomatic. And these are people in a study, in 3 studies. So I don't know what the rate historically has been out in the field. But so we looked at the players who went back while they were still symptomatic compared to the ones who were held out till they had at least 1 day where they were symptom-free in terms of recovery. So we are always worried about what's going to happen to these athletes if they go back while they're symptomatic. This paper, by the way, which I thought was a very great paper, I've never heard anybody talk about it except for me. And maybe a reason. I mean, this is why I think we have to examine our tenets about what we, in terms of what we believe about this stuff. So we looked at first of all, we're concerned maybe the injury characteristics were different between these 2 groups, and that's why some of them went back early and some of them were held out till they were symptom-free. Absolutely nothing. Acute injury characteristics were exactly the same in the 2 groups. The recovery, and we examined these data very, very carefully, was identical on everything we could measure: neurocognitive, balance, symptom measures. And in this overall group, we had 24 same-season repeat concussions. Thinking, aha, I bet I know which group most of those came in. Hypothesis, number 3 overturned. So 22 of the 24 same-season repeat concussions came in the group that was actually held out until they were symptom-free. Only 2 in the group that went back prematurely. So why that is, I still have no idea, and I wouldn't recommend, I wouldn't recommend going back while you're still symptomatic to reduce the risk of a repeat concussion, but it makes you wonder a little bit. Turns out that it's largely time-based. So most of them occurred within the first 10 days after the injury, probably reflecting that underlying period of physiological vulnerability that Mike referenced. But the takeaway message is you can't rely upon symptom reporting or objective testing to predict that vulnerability. It's really probably time-based. Okay, So I'm going to touch upon the first randomized controlled trial of concussion management, which was Mike's group in Wisconsin. These were adolescent emergency, I don't know why that keeps happening, adolescent emergency department admissions. So they were randomized to two groups. Either one group got 5 days of strict rest, and the other one was usual care, which is 1 to 2 days of rest and then graduated return to school and activity. The strict rest group reported more subjective symptoms and slower recovery, and this is probably what Jeff referred to and Mike's referred to as the possible iatrogenic influence on PCS. I mean, if you send the message that someone has an injury that may be more serious or concerning than maybe it should be, a certain percentage of people are going to have more symptoms for a longer period of time as a result. There's a whole emergency department literature on this too. If you take a group of people from the emergency department with a head injury and hand half of them the usual head injury care sheet, which has a list of symptoms that you could have, and if they get worse, come back or see your doctor, and you take the other half and you sit them down for a few minutes and explain to them about the natural history of recovery of concussion, you'll have a much better outcome in that group that you explained the natural history of recovery of concussion to. And that led the World Health Organization in 2004 to recommend that the only real intervention for uncomplicated mild traumatic brain injury should be a brief educational intervention, which is basically tell people they're going to be okay. Okay, now we get into the stuff that's interested me the most. I mean, I kind of felt like I researched myself out of a job in sport-related concussion a long time ago, and it's not what I do for a living these days anymore, but it's the most fun thing that I do professionally. So if you ask anybody out in the American population about evidence of retired NFL players having degenerative neurological disease, they will assume that it's an established fact, that these players are at high risk of neurological diseases, they die early, and it's just a terrible thing. And I'll blame Kevin, although I was on the paper as well, for bringing this up first from a survey perspective. And this was a survey of retired players who were self-reporting cognitive problems or diagnoses of mild cognitive impairment. And for me, I've still intuitively, I thought that there probably could be some significant risk in late life. If you've had a history of repetitive concussions or even a history of a long playing career with a lot of subconcussive head trauma, why wouldn't that place you at greater risk for earlier expression of age-related neurodegenerative disease? Okay, there's something known as cerebral reserve. So if you're chipping away at your brain reserve over time, then it's going to take less, amyloid burden, less, Alzheimer's pathology or Parkinsonian pathology or whatever it is to hit the threshold where it becomes clinically evident. And we know this. We know if you've had a big stroke earlier in life, it's going to take less Alzheimer's pathology for you to become clinically symptomatic because you've gotten rid of some of your brain that could absorb the damage from that pathology. So what we see here is that there's a relationship between the number of self-reported concussions and then self-reported and spouse-reported memory problems and diagnosis of MCI. I think this kicked off a lot of concern about what's going on with these guys late in life, and it still remains an area of concern for us. Since that time, there's been only one good epidemiological study of retired NFL players. It was published by Barron in 2012, and then Lehman followed up with a sub-analysis of the same data set. So 3,400 NFL retirees with at least 5 pension-credited playing seasons. They looked at mortality rates through to 2007, and they compared to US men who are demographically matched to them. The key findings here, and you never see this reported anywhere for sure, is that the all-cause mortality rate for the retired NFL players was half that you would expect from men of their age in the general population. So they're dying at half the rate you would expect them to die compared to the general population that matches them demographically. Their suicide rate is 40% of what you'd expect from men with this demographic background. Okay? So at first blush, they're a lot healthier physically, probably, and mentally healthier than men of their demographic background in the US. Here are the reduced death rates compared to the population. 63 fewer cancer deaths, et cetera and so forth. 94 fewer deaths due to injuries. 13 fewer deaths due to suicide than you'd expect. So look at these numbers and think about them for a second. When we go to the next slide, which is the thing that has been reported. So you have 291 fewer deaths than you'd be expected. Okay? What happens if you don't die of things that kill you when you're middle-aged or in your early old age? You die of things that get you when you're older, because you got to die of something, right? So here are the number of NFL deaths above the expected rate by the population. So all neurodegenerative deaths, there were 6 more than expected. 291 fewer deaths due to everything else, 6 more due to neurological diseases, which are late-life diseases. Does this suggest an epidemic of neurological illness in retired NFL players? Not so far. Okay. But if you look at this, and the way this is reported is there were 3 times as many deaths due to neurological diseases in retired NFL players than you would expect. That's not really the right way to look at these data. Okay. One other important thing is that those neurodegenerative death rates were not elevated in non-speed positions. Okay. The speed position players are the ones that have their all-cause mortality rate that's much reduced, probably because they're in better physical health overall. So you don't see the non-speed position players dying at increased rates of neurological disease at all in this study. There's only one other epidemiologic study. This is for high school football players compared to non-football playing male classmates, and they found no increase in the rate of any neurodegenerative diseases. So the epidemiology right now is that retired players have an all-cause mortality rate that's much lower than you'd expect, a suicide rate much lower than you'd expect. And if that's the case, then you kind of expect an increase in deaths due to late-life diseases. And what gets you, what do you die of in late life? Alzheimer's disease, other neurodegenerative diseases are more common the older you get. So the survey data, I touched upon this one before, and I'll try to speed this up a little bit. We sent out this general health survey, or Kevin really did this. We did a follow-up survey on cognition. There was this association between the number of concussions and MCI memory problems. We didn't see an association with Alzheimer's disease. Survey, of course, is subject to response bias. You don't get all the surveys back. You don't know the people that send the surveys back are more likely to have problems than the other ones. I went ahead and analyzed a group that completed a form called the AD8, which is a spouse-completed questionnaire about cognitive problems, suggested that 35% of this group might have some cognitive problems, which was a little bit alarming. It's like 1/3 of players, retired players, are reporting cognitive difficulty. The problem is we had no control, so I don't know if we sent this survey out to 513 plumbers if we get the same rate back or not. So Kevin did a study where he brought in 41 NFL retirees for an MCI study. I thought this was kind of interesting to give us an opportunity to look at the clinical characteristics of retired football players who were having some memory problems. So we matched them up to 41 controls and 81 clinic patients with diagnosed amnestic MCI, which is basically prodromal Alzheimer's disease. Okay. And what we found was that these NFL players with MCI looked an awful lot like our clinic patients with MCI. So maybe these are folks who are in the early stages of Alzheimer's disease. And this is a neuropsychological test. And what you see here is the green line are the controls for the NFL. So they're demographically matched controls. The yellow line is the NFL retirees who had evidence of mild cognitive impairment clinically. And the blue line is the clinic patients with MCI. So the profile looks very, very similar to clinical patients with amnestic MCI, suggesting that maybe it's not a unique neurological syndrome that these retired NFL players have. Playing in the NFL is not going to protect you against getting Alzheimer's disease or MCI, right? So it looks awfully similar. And if you look at the hypothesis that CTE is the cause of late life cognitive problems in retired football players, would probably suggest that they should look different neurocognitively. CTE is presupposed to be a tauopathy. So let's look at what a tauopathy looks like on this test. The blue line is a sample of folks with Alzheimer's disease from the University of Oklahoma. There's 246 of them. And you see that sort of characteristic M profile that you saw with the amnestic MCI before. And the red line is progressive supranuclear palsy, PSP, which is a prototypical tauopathy. You can see they look very different. So if you have a tauopathy, it looks very different than Alzheimer-type dementia in terms of the neurocognitive profile. So that study didn't lead us to believe that there was anything really unique in terms of a clinical syndrome of neurocognitive impairment retired NFL players. Hart did another study where they recruited people with problems, just as with this one. No evidence of a unique clinical or radiological syndrome. Same thing with the Casson study in 2014. And then there was one more study that came out this year. They looked at 42 NFL retirees with a mean age of 52, self-identified as having cognitive problems. For some reason, they arbitrarily divided them into a group that started playing before they were 12 and then after 12, small samples. They cherry-picked their measures, and they reported this in press release, that the group that started earlier was worse on 7 of the 9 scores that they looked at, suggesting that if you start playing football early, it's going to end up being problematic for you late in life. The problem is that there's no good rationale for that age 12 cutoff, and you wonder how that was done. That wasn't prospectively identified. They reported on 9 tests, but they gave them a lot more tests. And interestingly, they were worse on the RAT-4, which is a measure of reading, that neuropsychologists typically use as a measure of premorbid functioning. And that suggests that this group is probably different from the get-go. Those groups are probably different from the get-go. So again, no unique clinical syndrome, but if you see that study, be careful because it's overinterpreted from my perspective. So the survey data have suggested that you have these possible higher rates of MCI in NFL retirees, and maybe it's associated with concussion, but we have had no controls, and we have that problem with response bias that we have to be careful about. When we directly examine NFL players who are actually still alive, they don't seem to be any different clinically from folks who suffer from the various things that they are complaining of. So we haven't seen a unique clinical syndrome that suggests the existence of something like CTE. And so what do we need to do? And I've been pestering Mike and Kevin for 5 years to do this study, and they just won't do it for some reason. I don't know, you can talk to them afterwards. But you randomly sample a large sample of retired NFL players. You randomly sample, you get a demographically matched control group, and you go and you examine them to see if there's an increased incidence of cognitive impairment in the retired NFL players. It's an easy enough study to do. If there is no increased incidence of cognitive or neurological or psychiatric disease, then you've sort of answered the question. You don't need to go any further. If there is, then you have the opportunity for a prospective study to examine how that evolves, how it's related to neuropathology, and so forth. And until we do that, really what we're dealing with is speculation. So this is from The Onion. It's kind of a funny slide. Really don't send your brain in until you die. But we have had, you're all aware of high-profile cases of retired professional athletes who have killed themselves by shooting themselves in the chest and wanting their brains to be studied. Now, I don't know what was wrong with those guys, but imagine that you're in a severe depression, you're a retired NFL player, your thinking is distorted, and you come to believe that you have a fatal, irreversible neurological disease instead of a treatable depression. So your actions might be a little bit different. And I worry about hyping something like CTE because the negative consequences could outweigh the positive consequences of increasing focus on possible problems in late life in retired professional athletes. Okay, so we probably don't have time for questions, right, Steve? Okay, thank you.